hemodialysis catheter. Your patient comes in for any reason, and you know from his history, or you see he has a dialysis catheter. Your job is to assess that. One thing you're going to assess is you're going to put your fingers on it, and you're going to want to feel a thrill. That's the movement of blood through his device. You can feel it. It feels weird.
That's for both of them?
Yes. Because both of them are designed that you should be feeling blood flow through them.
I have a question. Sometimes, like, I get a lot of patients that come in with fistulas, but, like, sometimes they're just little small, like, you can see it, but, and then other times they're, like, gigantic. What causes that? Like, why?
The anatomy, the way they have it set up, how long ago they've had it.
Like, is it bad? Like,
No.
doing that?
If you are feeling blood flow through there, it's designed exactly how it needs to be.
I just
It is weird though, because sometimes you can just like, oh my gosh.
Like, sometimes
They're
they're, like,
hoses.
huge, and it's like,
It just depends on who put it in, what their need was. There's a lot. That's a
So
good
they were
question
like-
though.
but
I
it
know,
was, like,
it's
split
weird.
up that way.
Yeah.
Oh, okay. Like,
So your job, that's a normal finding, feeling the thrill. Yes, you need to assess blood flow through that, whether it's a fistula or a draft. So you're going to feel the thrill, that's normal. Abnormal is when you feel turbulence in there. So your job is to feel the thrill. Your job is to listen for a bruit with your stethoscope. Bruit is normal in this case only. I think all the other time we talk about bruit is bad. In this case, you want to hear a bruit. It's like a buzzing sound. It's pretty distinctive. So if you ever have a patient, even if you're not their patient, if you know they have a catheter, it'd be interesting if they would allow you to listen and feel the thrill because it's pretty distinctive. Normal finding, bruit. Normal finding, thrill. Abnormal, again, is like a whistling restricted sound. You'll be able to tell the differences between them. Trust me. Protect the access device. That is their lifeline. Give them an armband indicating they've got that catheter in place. No venipunctures, no blood pressures, nothing that's going to traumatize that site. Any questions on that? No tight clothing on that arm, no carrying heavy bags on your shoulder, all those other things we already talked about, like lumping and complication. She tells me, and I don't care what day it is, go through dialysis. Dietary considerations, I would not worry about that. It depends on where they're at with that. Sometimes it depends on lots of stuff. So there's no really hard fast rules as to what kind of dietary considerations to give to these patients. Sometimes we can do dialysis at home. Lots of things factor into that. Are they a candidate? Do you have someone that can do that for them, with them? Lots of things. And sometimes patients get an option like, I just leave dry in and get it done in that setting versus trying to fix this all up at home. Or I live by myself, or I don't know if I can do it. Lots of things. Complications in red and gold. I don't know if it's in gold, but it's in red. Biggest complication is low blood pressure. So think about the fact that you're pulling blood off that patient and you're taking it out. So obviously you're going to have issues with blood pressure changes. Questions about hemodialysis. Could you differentiate between 3 different devices? Know which was which. Could you know what assessments you need to do as his nurse? We also have CRRT. You as the ICU nurse may do that. These are patients that are too critical for hemodialysis. The patient we had on Monday that we saw their CRRT in place had a blood pressure of 80 over 56 or something, right? Really low. The nurse said, oh no, they're not stable enough to go to normal hemodialysis, so that's why we're doing dialysis here. And the ICU nurse is the one that set that all up and is monitoring that. She said, I went to like a 5-hour class, and we're time I had CRRT, it's just me and that patient. I don't have any other patients to take care of. Because I gotta watch the machine, make sure it doesn't clot, write all the findings down, things like that. So CRRT may be an option. Patients in ICU, patients who are critical for normal hemodialysis, and typically they run that continuously. You don't have to know the difference between them. There are different ways that those are set up. Third type, peritoneal. As you can see, there's not a lot of percentage of patients that get peritoneal dialysis. It's done through a catheter that's put in the peritoneum. You indwell fluid, you let it soak or set, dwell, and then you drain it out by gravity. And that's how they get their dialysis done. So the catheter gets placed, it stays in there as long as they get their dialysis. It gets surgically placed. It takes about 3 to 4 weeks to mature and be ready for use. So as I said, typically, this is done in the home. Typically, it's done by sometimes caregivers in the home. It's not necessarily you as a home care nurse. So we'll fill the peritoneum up. We'll let it dwell for a period of time, and we let it drain by gravity. The biggest complication is peritonitis, because oftentimes peritonitis is related, as we talked about during Jeopardy, is related to the fact that it's done in the home. The person hooking the tubing up to the catheter may or may not have healthcare experience, right? And that tubing is sometimes done, or that dialysis is done sometimes in the home, which may not be the cleanest of environments. There may be pets, stuff that contributes to that not really being a sterile procedure. Because either they don't have the knowledge that you do, the whole environment's different. So the biggest complication with peritoneal dialysis is peritonitis, and the biggest cause of peritonitis is that contamination from the tubing to hook it up to the catheter. Or you walk in there and they've got tubing hanging in the room, and no cleaning, and it's just hanging there for the next dialysis treatment, and there's stuff and people and stuff everywhere. Similar to what they would do with hemodialysis. Again, if you had the question there, there's different types. You don't have to know the difference between those. Dialysis, there's a lot of prescriptions for those. How bad are the kidneys? How effective is it? Can we have it less often, more often? All those things. You have to pay attention to your fluid retention, pay attention to your labs, and make those decisions on that. So, this is in red and bold as well. Your caregiver is giving dad dialysis through his peritoneum. And he calls and says, well, I got the fluid in fine, and then I let it dwell fine, but now I can't get that thing to drain. Well, this is what I want you to do. I want you to change your dad's position, raise his head to the bed, maybe move him on his side. Maybe we can just get that fluid to move by just you changing him around. Do not manipulate his catheter. That's your instruction as their nurse. That catheter was placed in there very carefully. It was surgically placed. It's in exactly where it needs to be. Don't push that catheter in or out. I just want you to reposition your dad, and maybe we can get that fluid to drain out just by you turning and moving him a bit. In red and bold, highly likely you'll need to know that. So there's lots of versions. You don't have to differentiate between them. Some of them are what we call continuous. There's no dialysis machine required with this one, right? You just need a catheter in place. There's machines that we hook up with this one to the catheter itself that adds fluid, lets it drain, and empties it. You don't have to differentiate between all these. There's probably more than this. Advantages: you don't have that device in your arm. It's not as effective. That's a disadvantage. Disadvantage is risk of peritonitis. So this is done through the belly. Advantage is you just got a catheter in your belly versus something that's in your arm, right? Disadvantage, sometimes it's not as effective. And advantage or disadvantage is that sometimes it's done in the home, so sometimes that's a good thing and sometimes it's not a good thing, depending on. The net effect is about the same. So now, we're gonna break for lunch soon. Now you have a patient who normally gets dialysis treatments and he's in for surgery. You're taking care of him today. And he's in for surgery. He can't go for his dialysis today. I normally go on Wednesdays, but I can't today because I got surgery today. Like, oh, okay, your dialysis normally gets rid of extra fluid. So as a nurse, you want to make sure that he's not retaining fluid, right? Because you're skipping your dialysis today because you're here for surgery or something, doesn't matter. And I know that your dialysis normally will take off waste and take off fluids. So therefore, as your nurse, I gotta be sure that you're not gonna run into a situation where you're gonna retain fluids. So I'm gonna carefully monitor that you're not showing signs of edema, fluid buildup in the lungs, fluid buildup around the heart, because you're aware that normally dialysis would take care of the extra fluids. Today you can't go for dialysis, so that's your job as a nurse, is to make sure that he doesn't get into fluid overload. And a lot of times now, of course, if they're inpatients, they can just go right down and get their dialysis done, but there's 100 scenarios where that may not be the case. Your patient has gone for some kind of kidney surgery. You're going to assess for post-op complications, as we've been talking about all along. I think we'll wait for kidney transplants until after lunch. Anybody have questions about what we've covered so far? I know we've covered a lot of conditions, but just ask yourself what's the most important part about that condition, what size of the kidneys, what's going on with this condition, what symptoms will they have based on what I know about what's going on with that condition, and is there any treatments that we talk specifically about that? And I won't ask 10 questions about the same condition because that's just not how it goes. Questions about anything we've covered. Is dialysis clear? If it's not, we can talk about it more, or you can ask